Welcome to the Next Step in Care learning series. This video is designed to provide healthcare and social service providers with ideas and guidance on ways to work together with family caregivers.
I think that we're obviously not going to have time in this session to give you a complete lecture about dementia. I will not mention neurofibrillary tangles, senile plaques, tau proteins, a wide variety of different things. And we're basically going to be talking about dementia and Alzheimer's as though they were synonymous, partially because Alzheimer's disease does represent the majority of cases, anywhere from 60 to 90%, depending on whose studies you look at. And the management issues for patients who have the other related dementia disorders are almost identical, except for some minor differences with frontotemporal dementia and Lewy body disease, which are probably not worth going into at this point. So the key thing here really is that we're talking about patients who have declining cognitive function that involves at least two areas of cognition, one of which should be an aspect of memory, the other one of which can be a wide variety of different things. And if that other thing is, let's say, spatial orientation, that may make it hard to set the table, but may not make a whole lot of other issues in the rest of your life, unless, of course, you get behind the wheel of a car, in which case you may be an extraordinarily dangerous driver. Or it could be in any of a number of other different things. If it happens to be in the areas of executive function, which were mentioned, that tends to be much more difficult to manage your life in the community. Patients can actually do quite well in their own homes with minimal assistance if their real problem is simply short-term memory loss. There are all sorts of different aids and supports that can be put in place. But if you can't figure out how to do tasks, and then you really are going to have a much greater need for assistance in the community setting. So simply saying someone has dementia, or they have losses in two different areas, and so on, doesn't necessarily tell you how much assistance they're going to require in the day-to-day. But the other point here is that dementia is a chronic illness. To make a diagnosis of dementia, these symptoms have to have been present for at least 30 days. And every different hospital and healthcare organization I know of has different kinds of screening tests trying to identify dementia, and there's one that's embedded in the MDS system, and most people are familiar with the mini-mental status exam or Folstein exam and so on. And all of these are actually relatively poor screening tests. They help to identify some people who have or may have a cognitive problem, but they certainly do not make the diagnosis of dementia. Some could have a mini-mental status exam of 17 and not be demented. They could have a mini-mental status exam of 29 and be quite demented. And because the whole point is that this is a progressive illness that's gone on for more than 30 days. So the most accurate screening test for dementia is repeated neurologic examination over time, because that's the only way you can really document that there has been cognitive loss that is a chronic progressive thing over time. There is no one snapshot test that identifies dementia when you're seeing a patient for the first time. And certainly for some patients who start at very extraordinary high cognitive function levels in some areas, there can be a tremendous amount of decline before they even go below 30 on the screening exam. I actually had a patient whose wife brought him in and said, his translations from Greek are getting terrible. He was a classic Greek scholar, and he had done translations for life, and now he was in his early 70s, and she also happened to have a PhD in classics. And she said, these are embarrassing. These are barely the work of a graduate student. And it's a little difficult for you on initial neurologic examination to pick up some of those subtleties, unless it's part of your routine screen to have people do a little translation for you. But delirium is actually a similar in some respects, but quite different situation. And the characteristic of delirium, by definition, is that it's an acute condition, and that the level of cognitive impairment fluctuates. Now, we know that dementia patients fluctuate during the day somewhat as well. In fact, even you and I probably have times of the day when we are higher functioning and lower functioning. Some of us are very good at 7 o'clock in the morning and pretty terrible at 10 o'clock at night. Others of us only do their PowerPoint presentations at 10 at night and are at their worst at 7 in the morning. It is normal for human beings to have fluctuation during the day, and it's certainly normal for Alzheimer's patients to have some fluctuation in function during the day. And the majority of them will do somewhat better in the morning and somewhat worse in the late afternoon. The famous sundowning syndromes and so on. That is the normal for that patient. We're talking about fluctuations that are out of the range of what is expected for that individual. And we're talking about disturbances of cognition, but also of attention and arousal. And this is extremely different from dementia patients, because dementia patients in general have extraordinarily well-preserved social skills. It's one of the things that actually makes the identification of early stage patients, or even some moderate stage patients, quite difficult, because in fact you can have extremely pleasant conversations with them. They attempt to respond to your questions with things that are appropriate or semi-appropriate at least, and will attempt to interact with you to the extent that actually, if you look at hospice criteria for the very end stage of dementing illnesses, it's so-called stage 7C, and the characteristic of stage 7C is that you no longer recognize familiar individuals and that you lose your social smile. These are the social aspect of behavior is extraordinarily well preserved in dementia patients. And so, you can ask them, how did you like, last night's TV program? It was fine. What did, were you happy with the results of the elections? Oh, they're all a bunch of bums. You can get a whole series of interactions with people. If you say that about politicians, pretty much everyone will agree with you in almost any setting. So, there are a whole series of kind of appropriate or semi-appropriate answers that people can give as they bat the questions back to you, and so on during the interaction. This is very different from a delirium patient who, by definition, is likely to have difficulty with levels of attention. So they have much more difficulty answering your questions. They're staring off into space and not responding to things and so on. When a dementia patient isn't answering your questions, it's because their hearing aid isn't in. And they tend to have much more disorganized thinking. And the key point here is that dementia is a major risk factor for delirium. So instead of having two nice, discrete groups of people, these chronic people over there and acute people over here, in fact, you're dealing with a significant potential, at least, for overlap, what's called delirium superimposed on dementia. And this doesn't seem unreasonable when you think about it for a second, because in almost any of our medical illnesses, we tend to have organs that are particularly vulnerable, and just in the same way that a COPD patient is likely to develop respiratory failure in the face of an upper respiratory infection, a dementia patient is more likely to have more severe brain failure because this is an already somewhat neurologically impaired organ. What do these two things have in common? Obviously that they overlap in terms of both having things which represent cognitive deficits. But the more important thing really here is that the time course is a key element in the diagnosis. So when you're seeing a patient for the first time, you are unable to identify what the time course of their illness is, and they are cognitively impaired. So if you're asking them, how long have you been confused, you are not likely to get an answer that's going to be very useful for you in terms of your diagnostic evaluation. So the point here really is that you need, to make an accurate diagnosis, the assistance of someone who knows that patient well, who unfortunately is not likely to be someone who's a healthcare professional, but more likely, in fact, to be someone who lives with that patient. And they are, in fact, going to be not just someone who helps to get the person to the exam and takes them away afterwards, and that you have to give the instructions on how to take the medicine. They are a key partner in your developing your differential diagnosis of what's actually going on with the patient. But that's actually kind of an underestimate of the significance of the caregiver in the evaluation for delirium.